everyone, welcome to ACE Internal Medicine ITE. Internal Medicine Training Examination have a lot of implications, my friend. It could destroy your internal medicine residency. You don't want to get into trouble with the IM ITE exam. That's why we're giving this series of lectures to teach you everything, the most common topic people usually miss in in-service training exam for internal medicine residency. Today, my friend, we're going to look at hyperkalemia and EKG changes, the most important. Another important topic when we come to internal medicine IM ITE exam, right? So let's look at first time, what happened? Potassium goes like around greater than 5.5. I think everybody knows this, probably tall T wave, but a lot of people don't know what's the mechanism, how does people get tall T wave. So what happened when the potassium reaches greater than 5 point, rapid repolarization happens over here. Okay, so T wave is going to shoot up. It also decreases the duration of the ventricular repolarization, which decreases the shortened QR interval, actually QT shortening, shorten the QT interval, okay? It shortened the action potential duration also. That kind of goes with the tall T wave. So remember, potassium 5.5, first thing is what? Tall T wave. What happened? Rapid repolarization is really fast, rapid repolarization. Your T wave is going to shoot up, you're going to have tall T wave. Now, one thing you need to understand, another important point is, tall T wave or big T waves can happen in like myocardial infarction also. So how do you differentiate that from hyperkalemia and myocardial infarction? Here, the duration of the T wave from here to is going to be short because of the rapid repolarization, okay? Here, the distance will be shorter in hyperkalemia, but the other one, that distance is going to be wider, remember that, okay? Now, let's look at what happened. The potassium hit greater than 6.5, okay? Sustained subthreshold depolarization happens, okay? Subthreshold depolarization, delay into the atrial and ventricular depolarization. So there's delay in conduction, right? Longer action potential duration. So what happens? Your QRS complex is going to wide. The other question, the examination can also, what's the phase associated with this action potential and all that? Decrease phase 0 of action potential. That's where the, all the sodium channels open up. Just, don't forget that. It happens when the potassium 6.5, sustained subthreshold depolarization, delaying atrial ventricular depolarization, longer action potential duration. So that delays in the AV and intraventricular conduction. Your P wave, first thing is the P wave is gone right there. Okay, AV conduction delay, P wave is gone or flattened. Intraventricular conduction, everybody know that intraventricular conduction is going, the QRS complex is going to be messed up. It's going to widen QRS complex, okay? You can also, what else? When you have interventricular conduction, you can have right bundle branch block, left bundle branch block, all of that. You can also have this, the first degree and second degree in AV block, but always remember, it's associated with a decreased phase 0 of action potential. That could happen. Somebody can ask you the question, okay? So next thing, like potassium greater than the extreme high, greater than 10, what happens? You got no SA node conduction, okay? Then what's going to happen? There is no conduction, intraventricular junctional rhythm, bad sign. This QRX, there's a merger is going to happen. Two companies are merged together. Your widened QRX and the T wave merged together. What do you have? Sine wave. Once you have the sine wave, patient is asystole, cardiac arrest, and death. That's gone. Okay? So it's important to understand all of these changes. Everybody knows some of the changes, but in order to go into a memory, let's what happens under the cell in the pathophysiology. Here, tall T wave, what is it? Rapid repolarization, decrease, APD, tall T wave, remember that, most important, okay? You can also have decrease because of the rapid repolarization. The duration of the ventricular repolarization is shorter. You can have QT shortening. When it hits 6.5, this is sustained subthreshold depolarization. Delay in atrial ventricular conduction, longer APD, Loss of P wave is gone. QR is saying make it bigger. And you can have left bundle branch block, right bundle branch block, conduction block, and all of that. The last phase, no SA conduction at all. So I know SA node is not going to work, no conduction, you're going to have accelerated junctional rhythm, and two companies kind of merge together. Widen QRS is going to go to T wave and said, let's merge together. They're going to embrace, you're going to have sine wave. So asystole is gone, okay? Remember that. Now we're just going to also on this side, I mean, it's good to know like how do you treat and all that. First, you need to give calcium gluconate to stabilize the membrane, okay? Because less arrhythmia. Number two, you give insulin, glucose, and beta agonist, right? Shift potassium into the cell. Don't forget it. Insulin, beta agonist, just give some nebulizer treatment and glucose, okay? Loop diuretic, like Localma and loop diuretic, Localma, Patriumar, hemodialysis, they remove potassium from the body, okay? So remember that part also. Remember how does it happen? Don't forget in the greater than 6.5, the link examination can ask maybe decrease phase 0 of action potential duration. Thank you so much for watching. We'll be back with another presentation soon. God bless. Take care.